Okay, I think we're ready over here if y'all want to get started. Right.
Yeah, that sounds good. Who do we have in the room over there at the primary care pavilion?
Uh,
My name is Mary. I'm one of the second year residents.
Great.
I'm Faris. I'm also one of the second year residents.
Awesome.
And I'm Amy. I'm one of the interns. And then you know me, I'm like you.
Great. We're really happy to have you all here from the family medicine program. We have a few other folks who should be joining us in later weeks, particularly from clinics in the Lake Jackson area, in Austin, and north of Dallas and Frisco. A lot of scheduling conflicts right now, but we are going to be recording all of this. So everything we talk about today will be posted online on our website, and you can always consult that at a later point. So see if I can get us started here. Okay, can everybody see can we see my slides after I share?
yes, we do.
We're good? Okay. I'm going to try to be able to see the thumbnails while I do this. Okay, so let's just get started here. Okay, let me know. Feel free to interrupt me if we have any audio visual problems. We love seeing people when we can. So if you'd like to keep your cameras on, that's great. You don't have to. We'll obviously leave time for questions. Most of us within the ECHO program here know each other, of course. I'm looking forward to getting to know more of you guys in family medicine. And as more people join our program, we'll all hopefully get to know each other a little better. Just so that y'all know where the funding for this program comes from, we are funded by NCATS through the Clinical Translational Science Award here at UTMB. I don't have anything else to disclose. So today I just want to talk about the ECHO program, what we designed it for, and our objectives with this program, as well as some practical tips for what is going to go on throughout this program, some tips to be successful in this program. So first, I just want the clinicians here in the room to think about a case that you've recently struggled with. I want you to think about someone with a behavioral health issue, psychiatric disorder, or a substance use disorder. And I want you to think about, what was it about that case that was challenging to you? Was it that you struggled to communicate effectively with this individual? You couldn't establish a therapeutic bond? Was the treatment planning difficult, that you couldn't decide on the right course of action? Maybe the case was a little bit overly complex and you felt that it was a little bit out of the bounds of your regular skill set and expertise? Or were there safety issues that you were concerned about? Was this a patient who expressed suicidality or was at risk for overdose, or you thought was misappropriating their medication? And how did you solve these problems? I'm guessing that most of you consulted a colleague, did some reading of evidence-based practices, but I'm hoping that in the future you feel a little bit more confident to deal with these complex cases or these difficult cases on your own, and that your patients feel better supported. And I want you to keep in mind what your typical struggles with these difficult patients are. What areas do you feel like you need to grow in as a clinician? And hopefully ECHO and this program can contribute to helping you with those challenges. I also just want you to briefly consider how you best learn, and keep this in mind as we hopefully meet your needs. Do you learn best through didactics, like you want to be handed the information and digest it on your own, or do you like more experiential learning, small groups, and hopefully you can engage more in the aspects of the program that meet your desired learning style. So BrainForward, this program is based on an ECHO model or extension of community health outcomes that was developed at the University of New Mexico. And the idea here is that frontline health providers are conducting the bulk of treatment for complex health issues that we normally reserve for specialists. So frontline healthcare providers are doing most of this work, yet they often may feel like with special complex cases that those require the expertise of someone they need to refer out to. And so the idea is instead of having providers feel like they have to refer out all these cases, what if we significantly improve the competency and expertise of people in these frontline care positions to approach complex, difficult disorders, and that would therefore significantly improve the overall quality and availability of services. And this is particularly true for mental health and substance use disorders, and I'll tell you why. So you're probably familiar with mental health disorders and substance use issues in your everyday practice. These probably come up quite a bit. But just a little bit of background on how prevalent these issues are. Anxiety disorders are probably the most prevalent mental health disorders. They affect about 1 in 5 adults, and they cause pretty profound functional impairment. You're probably used to seeing these just about every day in your clinical practice. Modifiable unhealthy behaviors are also leading contributors to the top causes of death. So how many times a day do you have to tell someone that it'd be better for them to exercise or get better sleep or cut down on their alcohol use, stop smoking? That probably comes up all the time. And so mental health issues and behavioral health issues are factoring into just about everything you do, probably. We're also in an era where substance use is unfortunately on the rise, particularly with opioid use, other prescription medication, which y'all are all probably very familiar with. Frankly, we're at the point where opioids are killing more people than car wrecks. And during this time right now, in the sort of wake or the short aftermath of the COVID-19 pandemic, we're in a time where mental health issues are particularly relevant. I read an epidemiological study the other day that said that over 10% of persons in a population level survey, over 10% of persons reported that they'd seriously considered suicide in the past month, which is, to me, just shocking that you would have such a high rate of individuals reporting this. Usually that rate is never above 3%, but that's where we are right now. Now, effective treatments, of course, exist for substance use, psychiatric disorders, but they're very, very difficult to access. Out of the at least 1 in 5 Americans that are currently experiencing a psychiatric disorder, only about 43% of these people will ever get care for their mental illness. And even those who do actually initiate some sort of treatment, most of them are going to drop out. So we in psychiatry call this like the one session problem, where a lot of patients will come in for a first session, but very few patients will follow through with that. We all know that there are problems with the mental health care system, but I want to introduce some of the major problems that are affecting why people can't get their care. And the first is stigmatization. A lot of people don't feel comfortable talking about mental health issues or drug or alcohol use, so they don't bring it up, or they feel like when they do try to bring it up, maybe their provider doesn't respond in the way that they hope they did. Another big issue is cost barriers. It is expensive to go see a psychologist or a psychiatrist. Let's just be frank about that, unless you have really good quality insurance. The other big issue is lack of provider availability and expertise. I'm sure many of you have probably referred a patient to mental health, to a psychiatrist, or psychologist, a clinical social worker, and I want you to ask yourself how long it probably takes them to get in to see a psychiatrist. And I would be surprised if it's less than 6 months. In the Houston area, we're the fourth largest medical center we're the fourth largest metro in the United States, with one of the best medical centers in the United States. And it probably takes most people at least 6 months to get to see a psychiatrist, clinical psychologist. And that just can't work. That's not sustainable, but that's the landscape that we're in. So we really need to make high quality care more available, and we need to increase the number of providers that are on the front lines with expertise to competently address these conditions. Now, I will argue that those folks in the audience in primary care, in family medicine, you are the ones who are doing most of the work with mental health and substance use disorders. It's estimated that up to 70% of mental health care is done by primary care clinicians. And of course, like we mentioned before, a lot of mental health issues, substance use issues, behavioral health issues have impacts on common medical problems. So they tend to suck up healthcare resources. So like it or not, these issues are playing out in the common primary care setting. And so we should address them in that setting where people feel comfortable and where they're getting most of their medical care. And like we talked about earlier, it's really hard to get someone from a primary care office to a psychiatrist. Traditional referral practices, I would argue, don't work in the grand scheme of things. We already talked about how long wait times are. Most people are never going to follow through with that. They're costly. So I would argue that when patients present with a mental health issue, they should be able to get care as quickly as possible, particularly if it's an issue that is addressable without inpatient treatment or really, really dedicated care. Now, you guys have received great training, and you probably do treat a good amount of mental health and substance use issues every day. But I would argue that typically most providers in family medicine lack at least in-depth behavioral sciences training. There's also a tendency for frontline healthcare professionals to rely mostly on pharmacotherapeutic approaches because, frankly, behavioral health is really hard to administer in those settings, and it's expensive, and they're probably not going to always get reimbursed for these things. And then there's also the tendency to refer out complex or severe patients to specialty mental health care settings, which I think I've already argued doesn't always work. Now, how can we make improvements to this system? I would argue that instead of sending patients to specialists, we should be treating them where they are. And so that should be their trusted, hopefully, primary care provider that's close to home. So they shouldn't be traveling long distances or spending a lot of money to see a specialist. That would hopefully reduce costs, wait times, and improve overall health and quality of life. And so that's where the ECHO model sort of comes in here. ECHO was developed as a collaborative model of health education that empowers clinicians to treat underserved populations with the best care possible in their preferred settings. This started with an initiative to improve the quality of care of hepatitis C in New Mexico. Now, in New Mexico, it's largely a rural state. and there's quite a sparse population outside of the major cities, pretty much outside of Albuquerque and Santa Fe. And so the people who started ECHO were running a gastroenterology clinic at the University of New Mexico, and they're receiving referrals from all over the state from these rural residents who were coming in for treatment of hepatitis C. And they found that their wait times were getting staggeringly long, and that physicians in the community were reporting that, frankly, I mean, people are dying out here because they can't get in to see someone in Albuquerque. They can't drive 200 miles to see a specialist. And the providers in Albuquerque were saying, I don't know why people have to come this far to see us. That Hep C really is not terribly complicated for someone to treat. And so what we should be doing is, instead of asking people to come see us, we should empower the clinicians in those areas to feel as if they can better handle hepatitis C. And indeed, that was a quite successful initiative. They conducted a lot of outcomes research on the improvements in hepatitis C care across the state, and people were very, very happy with the changes. So this model is being replicated throughout the world for various medical issues. You can find an ECHO in just about any state in the United States, as well as all over the world. The model, or the goal of the program, is actually to reach over 1 billion people in the next 5 years. So that's clinicians as well as patients. There are a few components of this ECHO model. I won't really get into the weeds on this, but we use technology to leverage scarce resources. So instead of going out and giving seminars to clinics all over the state of Texas, we would much rather get everybody into the conversation using video conferencing. We share best practices to reduce disparities. So we share what we do in a specialty clinical setting with you guys on the front lines. We're also going to use case-based learning tools. So we're going to hopefully have a lot of people present difficult cases, and we're going to work through those cases in these ECHO sessions to identify ways in which we can collaboratively improve the care for these persons. And as we work through those cases, hopefully that teaches you the critical thinking skills that we use in the specialty mental health care setting, and allows you to more easily adapt to complex and difficult cases. We're also going to ask for some information from you throughout the course of this program. We're going to keep track of your attendance, how well this program meets your needs, does it actually change your clinical practices, and how can we improve this in future iterations. And we hope to offer some benefits for you. There will be CMEs offered through the course of this program, and we'll tell you in a bit how to access those. We also hope that you'll gain a lot from the professional interaction here, and learning more from your peers. It's a bit of a mix of work and learning, so I think that people will enjoy learning about some really interesting cases here in the program. And of course, you have access to specialty consultation for your difficult cases throughout this program. Now, what to expect? Every session that we'll do this, we'll typically start out with just seeing who's on the call that day, and getting to know each other, and then we'll go through a didactic that is tailored to the specific topic that we're going to be discussing that day. We've outlined a curriculum that should hopefully walk you through the important issues in behavioral health and substance use disorders that are encountered in primary care settings. And so we'll follow a curriculum throughout the program, and you'll get about a 15-20 minute lecture by a content specialist in that area. Then we'll move on to case presentations and discussions. So hopefully, as we progress through this program, you'll identify cases that would be good to present to us, good to present during these discussions, and try to work out what those difficult issues are. And we'll talk about those cases as they come up. And then I'm going to also send you some surveys after our sessions to track your progress. Now, how to prepare, really, it's pretty simple and straightforward. If you're going to present a case, if you're interested in doing that, we have a web form for you to be able to submit that case to us ahead of time so that we're prepared for it. You just have to sign in to get your CME credits. Now, all of you are here at UTMB, so you sort of know the gist of that. We do it through Baylor, and you just have to send a text message. We'll give you that information beforehand. And if you have any questions, feel free to reach out to us at any time. I have an email here for the Center for Translational Sciences, as well as people can feel free to reach out to me. Just some background on how we will submit cases in this program. That works with the REDCap system. On our website, we have a link in which you can follow, and you just have to give us a little bit of information about your case in an anonymous way prior to the session so that we know that there are cases that are going to be talked about. We can weed out any confidential information if it did accidentally make it in there, and we can make sure beforehand that we have specialists who are able to discuss this case. So ideally, if we're talking about, for instance, opioid use in that day's session, ideally this would be a case that involves opioid use, but it does not have to be. So if a difficult case comes up and we're doing opioids, but this is a suicidal depressed patient, that's still okay. Now, as we talk about actual real-world cases, I just want to remind folks about the importance of confidentiality. Case-based learning, we feel, is really important to this model and helps you develop the skills for working with complex and difficult patients. But we need to keep this anonymous, and that's really, really crucial. So, of course, never identify names or any other identifying information. If that information does come up in a session, we will immediately stop and just say, hey, that was PHI, let's really try to leave that out. And you can also, I think, feel comfortable that if you choose to present a case in one of our sessions, it's going to remain anonymous because we're never going to repeat this information. In fact, while we record these sessions, we're going to record the didactics, but any of the case discussions, that's never going to go up on our website or anything of that sort, because I just don't want to take that chance that there was identifying information that was talked about, and then someone gets on our website to learn about opioid use and hears about their neighbor who was brought up. So you can feel confident that if you want to talk about a case, it's going to stay here. And we already talked about getting CME credits. I think y'all are pretty familiar with that. You have to set up a profile with Baylor College of Medicine, and I've put some instructions for how to do so on our website. Then prior to all of our sessions in which CMEs are provided, you just have to sign in by sending a text to a specific number, which we will always distribute to you prior to sessions. And then after your sessions, you just have to fill out a short evaluation form on the topic, and you'll get your credits. Now, just to look forward to what we have on the horizon for you, we'd really love to start out this program by talking a lot about behavioral health in the sort of era of COVID-19. These lectures will focus on the landscape of behavioral health right now. So what you can expect, you're probably already seeing a lot of COVID-related issues in your clinic. It's probably dominated your life for the past year. But I'll really try to dig into the literature and give you guys a very evidence-based update on what people are experiencing right now, what providers are finding particularly challenging, and maybe some strategies that have mitigated those challenges. During the second half of that series, so part 2, I really want to talk about any adaptations to evidence-based treatments for behavioral health issues related to COVID-19 or things that have become particularly relevant during COVID-19. So we'll talk about any adaptations to behavioral health approaches or pharmaceutical approaches. Now, 3 sessions from now, we're going to give a talk on assessment strategies in primary care settings for mental health and substance use disorders. We'll have a guest speaker, Dr. Cody Dodd. He's one of our new clinical psychologists here in the department, and he is sort of our assessment guru. He's going to go through some strategies for screening, assessment, and getting as much quality information as you can about patients, and how to use that assessment information to inform clinical decision making. Then we're going to also have a talk the week after that I'm really excited about. We're going to talk about how to briefly assess for suicide risk and how to decide what to do in the room about a patient who may be suicidal. And this is adapted for primary care settings. So this is how to assess for and deal with suicidal patients in primary care settings. And this is by a guest speaker, Dr. Craig Bryan, who's a specialist in suicide prevention. He's at The Ohio State University. And so I'm really, really excited about that talk. Now, that's all I have for today. I just wanted to give you guys an introduction to what we do, what we're looking forward to doing, so that you're sort of primed for this. Now, I'm happy to do any sort of discussion that people want to do, any questions that people have. So let us know what you're thinking over in family medicine.